I'm here from the Connecticut, Rhode Island Public Health Training Center, which is located at the Yale School of Public Health with a satellite office, actually, at Brown University in Rhode Island. And I'm actually here thanks to the Affordable Care Act, because thankfully the Congress at that time had the foresight to understand that having a well-trained public health workforce is critical to the successful implementation of the Affordable Care Act. Our training center is actually focused on continuing education to the public health community. Like many things in public health, that is very broad. In the course of doing needs assessments of the public health disciplines and agencies, we stumbled across the patient-centered medical home and the skills training that's needed, particularly at the FQHCs, which is among the reasons why I've also ended up here. I do wear another hat. I am also the president of the Connecticut Public Health Association, and we recently just had our conference where we looked at the transformation of public health, which is happening thanks to the Affordable Care Act and the new links that are being established between primary care and public health. I want to say on behalf of the public health community that we're embracing this. We have always understood that when you look at the person, their health happens not in the doctor's office, but out in the community, in their home, at their workplace, through their family. That public health is about assuring the conditions in which people can be healthy. So we are now thrilled to see this reconnection between primary care and public health through the patient-centered medical home. So now to our panelists. We're going to be kind of taking a bit of a step back, and first what we're going to do is have an overview of how the patient-centered medical home looks here in Connecticut, and that will be from Dr. Melhul Dalal, from the Connecticut Department of Public Health. He will be followed by Susan Starkey, who is a director of health that will give you the perspective from the local health level. Next, we are thrilled to have Sergio Matas from New York City, a community health worker himself, and he will be focusing on the big workforce development issue as we look at reconnecting public health and primary care, community health workers, followed by Neil Silverton, who will be talking about an innovative workforce development program that is focusing on the non-clinical workforce. So with that, I'm going to turn the podium over.
Thank you, Kathy, and thank you, Jill, for this invitation. So as Kathy mentioned, I'm going to start out with just a bit of a historical context about the idea of linking the medical home to the medical neighborhood. You know, in the future sometime, I would like to see the idea of a person-centered or family-centered medical neighborhood that will support the functions of a patient-centered medical home. But so I'm an internist by training, so my inculcation, if you will, into the medical home concept came about 10 years ago when I trained in a primary care program, one of the first primary care focused medical residencies for internists in the country. I had come on well after it was established in NYU, and we looked at something called the chronic care model developed by Ed Wagner. And if you take a look at this, does this have a pointer? It does. Great. We heard a remarkable presentation in the previous panel about health systems, about delivery system design, about incorporating decision support, about incorporating clinical information systems. The challenge is how we're going to link back to this broad community, which has been an integral part of the thinking around addressing chronic care. How do we link this to this broad community? And obviously, down at the bottom of the slide, we're all aiming for improved outcomes. So this is the 2011 NCQA PCMH standards. I can draw your attention to there's an entire standard around self-care support and community resources. But as you walk down the list, you can see that there are a number of points which would be directly supported or have a relationship to how strong a community support network would be to support the concept of a real patient-centered or person-centered medical home. Now, culturally and linguistically appropriate routine and urgent care, well, that could be facilitated, for example, by a community health worker, which we'll hear a little bit more about in the panel. The idea that, I'm going to drop down the list here, the practice identifies patients for proactive and point-of-care reminders. So again, this is something that can be facilitated by elements and supports in the community to identify patients who are at risk. And of course, there's a whole standard here around referring and linking to community support. Very broadly speaking, there seems to be sort of a barrage of acronyms and sort of a Tetris game of things coming from the federal initiative. And our job here in Connecticut is try to piece those together in a way that makes sense. So I'm just going to go through very quickly some of the things that will, from the federal level, that will help support the implementation of a neighborhood that supports the PCMH concept. So back a few years ago, there was a big emphasis from the Recovery Act on health information exchange. So this is the idea that we will be able to communicate from the provider perspective. We can communicate with other providers, but an expanded definition of health exchange would include such shared supports in the community, such as pharmacists. So imagine we could have bilateral communication with a patient's pharmacist about whether they picked up their medications, what their adherence was, and in the future, maybe we'll get a report, a medication therapy management report directly from the pharmacist in a health information exchange enabled world, and that would be great. We have meaningful use. There are many practices that are geared up to be meaningful use certified. Again, this broadly aligns with the goals of PCMH, of course. Kathy mentioned the Affordable Care Act. There's a prevention and public health fund. Those of you who are in the public health world have a lot of anxiety about it, but the good news is it's written into the law and funded. It could get cut, and it did last year, but it's there. They used it for those of you not aware, they used a big chunk of this fund last year to pay doctors for services for that Medicaid doc fix, which they haven't fixed yet. But it's there. One of the important aspects of the ACA in terms of clinical preventive services is eliminating cost sharing for preventive services. So those services that are deemed a Class A or Class B from the USPSTF, U.S. Preventive Services Task Force, they eliminate cost sharing for those. And these includes very simple things such as mammography, colon cancer screening, aspirin use in eligible populations. Another important initiative, which is sort of more of a leadership initiative that helps us orient to how we may do business in the state, is something called the National Prevention Strategy. The National Prevention Strategy, again, was in the ACA. It called on the heads of federal agencies to get together and talk about prevention and public health in their agencies. So you imagine there's folks from the CDC, obviously we've had a lot of expertise to that group, but also the Department of Defense, Department of Education. They get together and talk about how they're going to incorporate prevention as a core principle in their policies. So there's a lot of innovative work going on there, and there's actually an implementation plan that's available if you do a Google or other web search for it. There's language in the ACA, unfunded, about community health workers and primary care teams. So that's something that we can look to as a bit of guidance, and you'll hear later in our panelists how some of these things have actually been implemented, or models for implementation. What's happening in Connecticut? Well, actually, we've had a robust program at the Department of Public Health for a number of years based on the pediatric model, which has a long-standing professional tradition around patient-centered medical home or family-centered medical home. which is the Connecticut Medical Home Initiative for Special Needs Children. And that is a group that really does this care coordination and 2 minutes left, okay, and integration of services to smooth things out for kids of high needs. We have a medical home advisory council that has advised this group and future efforts around medical home in the state. The Office of Health Reform and Innovation has recently put in an application for a state innovation grant from the Center for Medicare and Medicaid Services. And they, for the first time, I was lucky to be involved in part of that effort, and for the first time in memory, CMS is including a population health focus and a focus on linking community care, community resources and community services to clinical services, baked in, to use a term that was before, baked into the grant application. So if hopefully we are awarded this grant, we're gonna have to think about it doing this way in terms of implementation in Connecticut. Again, not in my department, but the Department of Social Services has done a lot of thinking around a health neighborhood concept for dual eligibles in the state. The Coordinated Chronic Disease Program, which is under my purview, is a CDC-funded effort to help us to start thinking about chronic disease differently. Instead of in silos, we're doing heart disease prevention here, we're doing cancer over here, we're doing diabetes over here. There's a lot of things that can address those issues that are cross-cutting, including shared risk factors for a lot of diseases and shared strategies, at least in terms of the clinical side, that will be able to address all those diseases simultaneously. And finally, Sue may talk a little bit more about this later, the Community Transformation Grants, which is another large initiative funded through the Prevention Public Health Fund that is helping local level change to build healthy environments for active living, healthy eating, but also to enhance the use of clinical preventive services. So with that, I'll turn it over to Sue.
Now, I brought this great slide from the Centers for Disease Control, not because it's an Easter decoration, but it's because it's a good visual that shows that when you talk about public health, it doesn't mean just your health department. You're talking about a system with so many different stakeholders that play a part. Everyone here is a stakeholder, and there are different groups such as police or fire that are also involved. In Northeast Connecticut, we organized our public health system according to this chart that you see that describes a coalition where there are sectors that include arts and culture, work sites, education, food, and on the outside you see all the different potential partners that we can invite to the table. In the very center you see that we have a leadership team with names of people who come and meet every single month. They actually get to the meeting at 7 o'clock in the morning, and they share ideas. And even more importantly, they go back out and they bring back the ideas that they've learned to other members, colleagues, competition, people that are in the community that can help us participate in public health efforts. Our team includes various groups, the local radio station, the Chamber of Commerce, Day Kimball Hospital, Generations Healthcare, there's a social service agency, the community college, we have elected officials and philanthropists, and they all are working on important initiatives, and I wanted to talk to you about 3 of them. The first one is called the Right Steps Walking Program. It started in Plainfield schools, and every morning, everybody in the school goes for a 10-minute walk. First of all, the principal gives them a topic or a theme of the day, so they'll go outside and talk about what does gratitude mean to you. Then they'll go back in the classroom and they write in their journals about it. At first, the teachers were resistant. They didn't want anything to do with this when they introduced it in the spring. By the fall, they insisted that it come back because it was making a difference. They were writing more, their test scores were improving, there were less disciplinary referrals to the office, and the students were saying, my brain feels better. In Putnam, it took only one school child, Christian Suggs, who came to the health department and told us he couldn't compete in the school's competition to grow the biggest cabbage because there wasn't enough space on his land. So It takes a village. HealthQuest, the partners from the town, all got together and created a community garden. It opened this summer. The plans are to use it in the future as a place where we can talk about healthy nutrition, physical fitness, family-based activities. And then the third initiative that I want to talk about is one that's really exciting. It's a lot bigger. The Northeast District Department of Health got funding from the Foundations for the National Institutes of Health, along with the National Heart, Lung, and Blood Institute in partnership with the Million Hearts campaign, to introduce a program that would increase awareness that heart disease is the #1 killer of women. And we came up with a really different approach. We said that we would recruit 50 women between the ages of 20 and 65 to be models of heart health. We knew that if we brought in women, they could reach families, kids, all of their friends. And if we could entice them into doing this, we said, we'll offer you events every single month, and it will culminate in a Christmas spectacular where you will go on stage and present your whole new self. We put out a casting call in the newspaper and on the radio, hoping that we would get 50 people that were interested. We did. we got 189 eligible applicants, and we could not turn down any of them because they wrote us letters that said how important this was going to be to them, that it would make a difference in their lives, that they wanted to grow up and dance at their granddaughter's wedding. It was wonderful. So we had this great big kickoff event in February, where after the introductions were over, everybody broke into groups of about 10 and went to different stations. Remember all the volunteers from the community? They taught them a song that they will sing at the show. They taught them a dance. I still remember the moves about the symptoms of a heart attack, so you can call 911. They talked about yoga, sleep apnea. They talked about computers because we have a web page and a Facebook page that they can go on. And we did all this so that we could keep them entertained with Zumba. They were active. They were sweating with sweatbands and things like that. But we had to keep them busy because we tested all 189 of them. We got their height, their weight, their neck circumference, waist, and hip circumference so that we can follow up on that later. But after that was done, each different agency that's part of our coalition hosted events over the course of the year. And every event had an education component, a physical activity component, and healthy food options. So when we used the money from, when we kicked it off, we thought that something would happen at the end, but it grew bigger than anything that we expected. The models started doing things on their own. They started walking groups. They started posting that we're meeting at a dam or we're meeting here, so you'd start to see women in red dresses everywhere. They started doing things like potluck dinners, and we started to see signs of success, early signs, like people writing on the webpage that their doctor had taken them off their medication because their blood pressure or their cholesterol had gone down, or that they were ordering smaller size shirts. It was really exciting. And it wasn't just the models that were being impacted. There were people that saying now their grandchildren go to the house, and instead of going in the cupboards for the cookies, they're looking in the fruits and vegetables bin to get their snacks. The businesses that helped us with this, their business is booming. The healthcare facilities are increasing people. The models set up a stretch band class in a farmer's market that isn't used that night. So it's doing all kinds of exciting things. We just had a screening test where people are going back to get all their measurements taken again, and we got an email message from one of the practitioners saying, I got permission and I started taking pictures because you would not believe how happy these women are bouncing off the walls because things are going so well. So I just wanted to actually close this up by saying that we're really making a difference. We know we can do something. We get that idea of the fruit tree up in rural Connecticut. We are creating the soil because home is where you live, and we can create healthier communities. And I mean personal health, physical health, mental health, social and economic well-being. We're doing all that because we're working as a system in partnership to create a strong public health system.
Hi, good morning. My name is Sergio Matas, and I want to thank the folks that put this together for inviting me to come and share 6 minutes with you this morning. Oh, wow. Well, thank you. So I want to make 2 comments to frame my discussion. One is an image put forth in a recent article written by Rebecca Oney and Paul Farmer, which was released, I guess, 2 months ago in the Harvard Innovation Review. And it's called Realigning Health and Care. For those of you who have not read Paul Farmer, you should go out and buy everything he's ever written. He writes a lot about power inequalities and inequities and how power causes a lot of how power is the root cause. Power and poverty are the root causes of most of the illnesses that we see in our societies today. He's an enormous writer. Anyway, this article talks about how we really need to reconsider our understanding of who is a provider. And furthermore, we need to expand our understanding of what is it that a provider provides. And lastly, where is it that this provision is taking place? We heard some comments earlier today about, we've done this before. I did this 20 years ago, and this is true. In our efforts to improve the health of our communities, we keep rearranging things, but we're rearranging the same things, right? And that's not, it's not working for us. We are continuing to expend huge amounts of our national treasure on healthcare, and we're not doing that well. There are developing countries that are doing better in outcomes than we are, and yet we're spending $27 trillion. That's extraordinary. So this is, rearranging this stuff is still giving us the same stew. We're not getting anywhere. And so we're in this era now where we're talking about innovation and change and reform and redesign and transformation. And I haven't really heard anything innovative yet. CMS just put out all these huge grants, right? Everybody applied for them. My mother applied for them. Right? $10 billion, hey, come on, you can apply. I read 32 of those applications, and 2 of them had something that was innovative, that was something new. So I say this because, and this is because of what Paul Farmer said, it is difficult for us to be innovative, and it is difficult for people who are in power to be innovative. And so it's challenging. The second thing I want to say is okay, I'm going to push a little bit. You realize that health happens in the community, right? When Susan was presenting, I saw smiles and I saw nods and at her examples of how people are becoming empowered. I saw people responding to that kind of stuff. That's what happens in community. People become healthy in their communities. We don't do health in a medical setting. You get that, right? We do disease management in a medical setting, right? We don't do health there. Okay. All right. So, enter. Oh, that's me. All right. So I'm here to talk to you about community health workers, and that's not a clinical role. So I'm going to ask you to think outside the box. And I'm gonna and this is I didn't make this up last night sitting in my hotel room. This is evidence-based. There's a bunch of work that is behind all of this stuff. But community health workers have been around forever. But there's a lot of confusion in the modern understanding of community health workers about who is it that, who are these folks, and what is it that they do, and how is it that they do what they do. And there's a lot of interest now in community health workers and integrating them into these evolving healthcare team innovations that everyone's very excited about. So it turns out that CHWs actually have a definition. It's not up to, in the past, it's been up to employers to decide who CHWs are and what it is that they do in their description. Well, there actually is a definition. We developed this, it's a national definition. We submitted this to the Department of Labor. and the Department of Labor granted us a unique occupational category. So now we are a job category. We have a definition. CHWs are mentioned in the Affordable Care Act as health professionals and as members of the healthcare workforce. All right, so for those of you who were confused about, who CHWs are they professionals, are they not? Well, it is the law of this land that yes, we are. We're health professionals and we're members of the healthcare workforce. And the Supreme Court has upheld that. Yay for our Supreme Court. I think as Justice Roberts gets older, he gets more mellow. That happens. The other big thing is that in very hierarchical systems, there's this tendency to think of some people as professionals and some people as para-professionals. You should just understand that para is archaic. It's gone. It's old. The only people who are really holding on to that are really very bureaucratic and hierarchical structures like the military and healthcare. So there is a definition for CHWs, and there should be no more confusion about who they are. So the next question that begs is, so what is it they do? And we did, oh gosh, I've dedicated the last 3 years of my life to this. But this is a scope of practice for CHWs, and it was developed through consideration of the existing evidence base and a lot of original research that we had to do ourselves. This is a very contemporary, and it was developed by the leadership of all significant stakeholder sectors, including academia, employers, financiers, payers. CHWs themselves were in leadership of the development of this scope of practice. And we really searched all the existing literature, and then we did a lot of our own original research. It's published in the American Journal of Public Health. If you're interested, just contact me and I can send you that stuff. But I want to call your attention to some of the more modern considerations in this scope of practice. And one is, So we did all these surveys and interviews and key informant discussions, and at the end, when we analyzed all the data, we had about 38 elements that people told us CHWs do. This is what we do. That CHWs and employers and everybody else told us this is what they do. So we were challenged really to figure out, well, what do we do with all these elements? And what it turned out was that we had to do this functional task analysis. And for the purposes of this discussion, what that yields is it helps you understand what a role is, and a role is a big purpose, like the reason that you do things. And then a task are activities that you engage in to achieve that role. And then there's a skill set that goes with that you need to do the task. And that's what these are. These are roles, 7 roles, and there's some tasks under there. You will notice, okay, let me leave that there. And then lastly, I want to say that CHWs work across a continuum from service. They do deliver services, but they also, at the other end of the continuum, is an empowerment function, which is the stuff that made you feel all warm and fuzzy when Susan was presenting before. Like, we really want to help people become empowered, and CHWs do that. And of course, everybody wants, well, what's the dollars? We did an extensive financial analysis of the work of CHWs wherever it was possible. We just completed a meta-analysis, and these are the numbers that are coming in. In general, the return on investment for a CHW is somewhere between $1 and $7. So for and averages out to about 4.5. So for every $1 you invest in a CHW, you get back $4.5. That's like a lot better than my 401k. So. I want to say just one more thing. We just finished doing an in-depth case study of a single PCMH in New York City that has completely integrated CHWs into their full operation and really created cultural changes within that institution. It is a Department of Family Medicine, which is located in the South Bronx, which, if you don't know that area, is a severely impoverished and underprivileged community. It's a largely immigrant community of a number of cultural groups, including Latino, Asian, and African groups. they brought in some CHWs, and they fully integrated them into the system. At first, there was some resistance. This is also a teaching hospital, so there are residents all 3 years. There was some resistance, but they've really created a cultural change where now CHWs are welcome by incoming residents. And in fact, the third year, second year, older residents really look for their CHW. Like, they freak out when the CHW is not there. They want to, like, where's my CHW? I need my CHW. The chief and medical director of that family practice, family medicine department, has created teams, pods, some people call them. And each team is an attending, PGY3, PGY2, PGY1, a social worker, and a CHW. That's the team. And the CHW runs the team. The CHW runs grand rounds. The CHWs do case studies. The CHWs, yeah. And they've created extraordinary results. So my attempt was to give you the 35,000-foot view, but there's a lot more detail as you come in for a landing, and we'd be happy to share that with you.
Hi, my name is Neil Silverton, and I'm going to do the best I can to speak after Sergio. I should say I am a bit blurry-eyed from watching too many debates, so I just want to apologize in advance if I blurt out that someone's numbers don't add up. But I really do want to jump off of what Sergio said, because what I'm going to talk about this morning is the idea of building off of this really important role to develop pathways inside the healthcare system for advancement that both help to sustain the role as well as help identify growth opportunities for individuals that have tremendous potential. And I do want to refer back to what Dr. Borkin said first thing today. He talked about inside the health center, I think he used the word, these are different MAs. And they are, and it isn't just MAs, but I think we're thinking about how we can build off the frontline role. And the largest frontline role inside the health centers is the medical assistant, and how we can incorporate other aspects into that and help to build off of that. Just a little bit about Workforce Partners, because it kind of sets the context for how we've approached this work. Our focus is workforce development, helping organizations identify workforce needs and build programs to address those needs. And our focus is very much about the employers, about the providers, and if we can design approaches that fit within how providers do business, we can help to sustain approaches to career development. So we're currently working, and I'm doing this for the last year or so, in Connecticut and California, helping to design career ladder programs for frontline workers inside community health centers. And really the idea is we want to think about sustainability, because we know these roles that Sergio and others have described are really critical, but in many cases they're not reimbursed by the healthcare system. And our approach here was, if we can begin to identify how these roles work within how providers will deliver care, then we can begin to build this in and make this more sustainable. So basically the approach that we did in both California and in Connecticut is to really work with providers to understand what their needs were. And I think you'll recognize a lot of the competencies here from what was presented a little bit earlier. So we basically did a drill down. And as we talked to providers, it seemed to us that if there's 1,200 federally qualified health centers across the country, all 1,200 are moving towards the PCMH model now. But to us, from what we heard, it wasn't just about checking boxes. It was real systems transformation going on here. So again, it comes back to this frontline role, and how do we take advantage of this tremendous opportunity? So again, these competencies will be familiar to you, but as we heard from providers, if we're going to move towards a patient-centered model of care and help patients self-manage their care, we need our frontline workers to do some different things that they were doing before. So here, again, these are, I think, things that are familiar to you. We want to move the medical assistant to begin to do health coordination. Can I make sure that the patient's in the room and that she's prepared for her visit? Can I ensure that the provider understands her patient and how to work with her patient? Can I make sure that that you're getting to the foot exam and you're going to the right place within the healthcare system. And then we get into issues like coaching, which come up. Again, if we're going to help patients to self-manage their care, we need the frontline workers building that trusting relationship so I can work with you on your care plan. Why are you not adhering to your medication? Are there things that we can work through that don't just happen about how you understand your care, but we recognize that there's things going on in your home life that might impact your ability to support your care. And lastly, panel management. So these are just a few of the competencies that are really bubbling up as we talk to the health centers about this work. And really, and I'm going to apologize in advance because I'm going to muddy the definitions a bit here, because we really are talking about a combination of different roles, from the medical assistant that's very task-oriented and has a medical background, to some community health worker competencies, to front desk. It all kind of rolls into one as we move up the healthcare system. So based on this, our approach was to develop career ladder pilots. So the idea is that we want to work with providers, and we're doing this in the Central Valley in California and in San Diego, who have made the commitment to move towards patient-centered care, and help them build their care teams and build the skills of the frontline workers to be a key member of that care team. And we're also, again, I want to come back to this issue of sustainability, because I'm going to talk a bit about training in the next slide, but we're going to be asking employer providers to commit to investing in staff, not just to train, but to promote. And we're talking about wage enhancement, that we can imagine that a medical assistant that moves up to care coordinator 2 could get a wage increase of $4 an hour. And where's that money going to come from? To my earlier joke, the numbers right now don't add up. So we want to think about how we can help community health centers be rewarded for the work and the investments that they make. So the approach that we're taking in our pilots is to partner with local Medicaid health plans. And so in San Diego, we're working with Molina Health Plan, a large Medi-Cal provider. And what we've asked them to do is work with us in the design of the training pilot, help us develop the metrics, and help us track the metrics, because if a key metric we're trying to move the needle on is reducing readmissions, the health center doesn't always know, but the health plan does, and they'll work with us on tracking these metrics. And secondly, we want them to take this pilot, look at the results, and make this part of the conversation around how they can redesign incentive payment processes. So we know that you can't have service transformation, healthcare transformation, without payment transformation. So we feel that these pilots can be a big part of the conversation going forward. So the last slide I'm going to talk about is education. If I come back to the medical assistant role right now, we hear, and this may resonate with many of you, that the quality is a bit uneven with medical assistants today. Many of them come from proprietary training institutions. Many of them lack foundational skills. So we want to take a pretty big paradigm shift here and begin to move this to become part of a community college educational track. So what you'll see here is we're looking at a pathway from GED to the career education, work-based learning, and we want to make sure that I can look at this role. Maybe I'm a promotor today, or a medical assistant, or a front desk clerk, and I can see where I can go into this system. So I want to make 2 more points about this. One is, in California, we're working with the Community College Chancellor's Office, who's looking at how they're going to redesign their MA program, and they're going to incorporate the results of the pilot, and we'll work with them to design their curriculum for that. So we see this as part of an educational track. In Connecticut, we're working with Norwalk Community College. The second point I want to make is we don't see this education as just about the classroom. In fact, maybe not too much classroom at all, but rather e-learning and work-based learning. So what we've talked about with our provider partners is the idea that the nurses and the mid-level providers will take on the role of preceptor to help assess the care coordinator 1s and care coordinator 2s as they move up the ladder and demonstrate competencies. And the last point I'll make about this slide, and then I'll wrap up, is it comes back to we want to strengthen communities, and we want to help people find avenues for advancement. So in a lot of ways, the MA role has been sort of a dead-end role. But if we can begin to create some progression and build your foundational skills, so by the time I've advanced to care coordinator 2, perhaps I've gotten up to college-level academics, and now I'm ready to jump even further, whether it's I want to get on a track in nursing, allied health, or social work, that we've now created this pathway for people that can jump into public health and advance further. And lastly, when we think about workforce development, we've always talked about the dual customer, the dual bottom line of helping people grow and helping organizations grow and thrive. And really now there's a third bottom line for us, and this has been really exciting, is that we're helping people grow, we're helping organizations grow, and we feel like we can tremendously increase access to healthcare, because these are the frontline workers that are going to enable self-care and are going to enable access. So thank you very much.
Well, I'd like to thank all our panelists. They've done a wonderful job of covering a lot of territory. As you can see, public health is very big, but vital. So we have about 10 minutes, and I would just like to open the floor to questions to our panelists. In the back there?
This is about nursing and nursing education. In Connecticut, we have a community college system that has a common curriculum, and we have about 1,200 students, Norwalk being one of our sites. And I'm wondering what specifically is being done with the nurse educators in the state to help to implement this in a more systematic way in our curriculum. There are pieces of it that I know we all do, but I'm wondering if you're working with nurse educators to help them to develop specifics. Thank you.
We'll be working.
Whoa.
Usually I have the other problem. We'll be working with nurse educators as part of the precepting process, because one of the roles that we've identified is in a sense an education extender, to extend that function. But as we think about the career pathway, we're looking to do this for college credit and begin to stack in the way that will prepare people to step into programs like nursing, allied health, and social work. But we see the work with the nurse educator around precepting and on-the-job training.
Yes.
I applaud the idea of having the medical assistant have some kind of standardized training, because if you remember the 1990s, the trouble we got into with unlicensed assisted personnel all over the country, where there were all kinds of things coming out of the newspapers because there was no standard of educational practice or certification.
Thank you. Other questions? We go center aisle.
I just have a question for Mr. Matas about the community health workers. I think, I mean, the role sounds like a phenomenal role that I personally am not really that familiar with, but I work with a home care agency, and my team personally services inner city Hartford. So, you know, community health workers would be a fabulous addition to our team, but is there currently a reimbursement source?
That's always the million-dollar question.
Yeah.
Where's the money? Yes and no. Most CHW programs right now are funded either through grants or through Department of Health and Departments of Public Health programs. Departments of Health and Public Health have huge maternal child health programs, and the HIV institutes generally fund CHWs through government funds. Some commercial, more progressive commercial insurance companies, both private and commercial, are financing CHWs. Because of the business case that I presented there, and it's a larger argument, a lot of organizations are now integrating CHWs into their operating funds. So they're starting out with grants and finding these huge returns on investment or value added, and then integrating them into their operating budgets. We're working very closely with our own state health department in our Medicaid redesign efforts to really integrate CHWs more fully into evolving innovations. We're moving more into health homes in New York now. We're kind of, PCMHs are kind of done. I mean, you know, the establishment of those is established. So the innovation now is really health homes, which completely changes financing. But thank you for that question.
Okay. More questions?
Question about the preceptor scenario. I mean, I already work with Provider Group, and they have nurse practitioners, PAs, and MDs who are already precepting. There's a big drag in productivity with the changing system, implementing EHR, PCMH, ACOs. How do you plan to help, as you're now talking about precepting and a new development of precepting and who's being precepted, how do you plan to accommodate for the precepting that's already occurring and maybe helping with some of the productivity issues?
Right, carefully. You know, and I think the approach we're taking is to develop pilots. So in San Diego, we're going to pilot this in 4 sites. In the Valley, Central Valley will do this in 3 sites. So we're going to start small. And as we're developing budgets for these pilots, we are planning on budgeting and precepting time, because we do realize it's part of productivity. But long term, we envision the precepting model being part of how you do your job. So part of the challenge of these pilots is to develop not just the training for the MA to care coordinator, but to develop the training and the sustainability for the preceptor role.
Thank you.
Is anybody working with home health aides on this kind of thing? I work for a home health agency, and we've incorporated home health aide coaching into our chronic disease best practices. And this state is getting ready to implement home health aide medication administration very shortly. So are you aware of any programs that are training home health aides to take the next step?
I do want to say one thing quickly about that. And part of the approach that we want to develop with career ladders is to make sure that it's competency-based, so we can be transparent about it. So if I'm a promotora, a home health aide, and I can look in the college catalog or see a provider, these are the competencies I need to gain to move up, then we can create movement from a whole lot of different positions, recognizing that the community health worker role is unique and requires a unique set of skill sets that not everybody has. If we can be clear about what it is you need to have, then we can help that kind of progression.
As a follow-up to that, didn't matter which one came first, are you looking at all at the non-medical workers, the true direct care workers who, PCAs and that type, that we're going to need to help with the aging population?
Lots of good questions.
I mean, yes and yes. I mean, in the San Diego pilots, we're going to start really just with MAs. But in the Central Valley, we've kind of heard your point, which is the skills that it takes to support self-management are unique, and they could come from someone who's on the front desk or a CNA. So if we're taking the approach to make sure that this is competency-based, and it becomes a question not of becoming an MA to go here, but to fill in a set of competencies through work-based learning and perhaps a modular approach to education that will help people from any point in the system come into this role.
Anybody? Sergio, could you talk a little bit more about the training for the community health worker? What does it entail?
Yeah, thanks. I was actually going to answer that in response to this other question. When we started our project 3 years ago, our purpose was really to change financing, to really change the way we finance CHWs, because the way that we don't finance health, first of all, we finance disease management. And we do that very categorically and in a time-limited way. And the work of CHWs really isn't that. We don't work for a little bit of time, and we don't call you 3 times. If we don't catch you, you're done. That's not the way we work. And so the existing financing didn't work. So we needed to change financing. We were told that to change financing, you're going to need a credential, because nobody's going to pay. You need to hang it on something. You need to hang payment on something. And if you need a credential, then you need training to get that credential. And if you need training, then you need a scope. And so I gave you the scope. I couldn't give you all this detail from 35,000 feet. But the training that we developed was in direct response to what the market told us. It's in direct response to that scope of practice that I presented to you. And it contains 2 things. It contains content. So there's a skill set that you need to conduct that scope of practice. And then there are health and disease-specific topics that are specialties. There are also recommendations about pedagogy, about methodology. CHWs are non-traditional adult learners by and large, and so lecture generally does not work. Lecture doesn't work for anybody, but and so we have many recommendations about adult learning, interactive, experiential learning, discovery processes, popular education philosophies and approaches that CHW should be taught. I want to say, the healthcare sector is very invested in academic achievement. That's kind of how we measure everything. CHWs aren't really about that. CHWs bring a set of life experiences that make them valuable by themselves. And so it's not really, it challenges us because we're integrating, and the example that I gave you where, you know, the residents were saying, who are these high school people leading RT? You know, what's going on in this place? You know, it's challenging, but it's extremely rewarding.
We have time for one quick question.
It might be more of an observation, but I wondered if you could comment on this. Yesterday on WFSB, there was a story that ran in Connecticut News about a volunteer at a UConn football game at Rancho Field who had a heart attack in the stadium, and there happened to be a community physician there who administered, you know, the first services. They got the guy in an ambulance, and they got him to St. Francis Hospital, where one of the doctors I worked for, a cardiologist, you know, did an angioplasty and so forth and saved the guy. And, you know, so it was this big story. But nobody really sees the failure in the story. The failure in the story is that, you know, nobody intervened in this guy's life 20 years earlier to not have him on a progressive route to cardiac disease later in life. And every single day I go into my office and I have 100 people that cycle through our office with moderate to severe cardiac disease. And I will always have, you know, rooms full of patients waiting every day who have this type of disease, because nobody's really getting to these people, you know, earlier in life to prevent this. And this is how everything is financed, and this is the track we're going to stay on. This is the track we're on. This is the track we're going to stay on. And it seems to me all of you are talking about just complete rejection of that, you know, whole notion and intervening in people's lives, like what you did in getting people active and healthy in the community. It was all about reducing weight and preventing heart disease. So how do we make these things happen on a scale and sort of get out of the rut we're in of filling my practice with people with heart disease?
It's building community will that really makes a difference, and one success building off another. You brought up the example of somebody saving somebody who was having a heart attack. Actually, the Office of Rural Health granted us money so that we trained almost all of the models to do CPR and the external defibrillator, so that it increases the number of people that can respond if somebody does have a heart attack. And that increases your chance of survival. But it's because those people volunteered, the money's going to run out at the end of the year. So we have to find interest among all of our partners to continue to do things like this. One of the things that I didn't mention is that the leadership team that we have in place is funded in part with community transformation grants that are part of the Affordable Care Act that will bring money to bring system change. We have to come up with a plan to implement something new. And I can see that implementing community health workers could be a really important goal across the entire state, but it's a very nascent effort there. We're just having the conversations about what are they, how will they be trained, where will they work, because nobody has money to pay them, because we haven't figured out how to reimburse them. But it's an important conversation.
Yeah, and I would say that success in building healthy communities is to rebuild communities. We've taken power away from communities. We've colonized communities with our service industry, and community has lost a lot of its power. And reinvesting in the health of communities is where people become healthy.
Well, I'd like to...
I'll add one more thing.
Okay. It was a great closing comment. Thank you. Yeah, perfect.
Yeah, I'm not going to add anything to that comment, because that comment was exactly right. Our focus is on, and the news stories are these heroics that happen, but the lesion and the failure in the system happened 20 years ago, and that's exactly right. What is the approach? I think the approach is to really take that prevention paradigm and institutionalize it. There's an approach called Health in All Policies, which the National Prevention Strategy is one of them. But everyone has to take a look, whether at the federal level, state level, institutional level, in your healthcare settings, are your institutional policies promoting prevention and health? That's where it starts, because health begins, as Kathy opened the session, where, and I'm borrowing this phrase, where we work, where we live, where we play, where we worship. All those places have to be areas where health can be produced. It shouldn't be managed on the clinical side. Well, that's a part of it, but it shouldn't exclusively be managed on the clinical side.
Thank you.